Hello and welcome everyone, and thank you so much for joining our ICD-10 and CPT code changes webinar today. My name is Sawyer Barkus. I am a product marketing specialist here with ChiroTouch, and as always, I'm so excited to be here today. As a thank you for joining today, we do have a special sneak peek at a new ChiroTouch Cloud feature that we've been working on with the help of KMC. This feature is coming soon and will help transform your billing and compliance. We'll be talking more about it toward the end of the webinar, so be sure to stay with us to get an exclusive look at what's next for ChiroTouch. With that being said, I want to extend an extra warm welcome to Kathy Weidner. Kathy Weidner, better professionally known as Kathy Mills Chang, is a Colorado girl residing there with her husband, Michael. Kathy started as a CA in 1983 and just a few years ago celebrated her 40th anniversary of serving the chiropractic profession. In 2007, Kathy founded KMC University, which, as many of us know here, is the profession's go-to for training and resources on Medicare, documentation and coding, practice finances, compliance, and business essentials. The KMC University Library houses the broadest and deepest compendium of training and tools available in one place, online, for easy access. Her team of 15 also includes the most certified specialists under one roof in the profession. With that being said, I will pass things over to Kathy now.
Thank you, Sawyer. So as we're getting started, I do want to make a very clear distinction. And this kind of started way back when this webinar was conceived. ChiroTouch loves to do this webinar with us every year. And in some of the initial promotion, it was indicated, hey, come hear about all the new ICD changes, all the new CPT changes. I want to say from the very outset, there are no changes this year. And you probably already know that since we're past October 1st. But there are some really important other things, and I'm going to dig into those CPT and ICD a little bit anyway. But I just want to be sure that we're very transparent about the fact that this is what it is. But what you need to be doing between now and the end of the year is also very, very important, and equally as important as knowing what those changes are. So that's what I put together for you here today. And I will certainly be happy to field questions as we go. So we're going to talk about a number of these things as we go through the time together today. And where we want to kind of start is this idea of why we have any oversight of our profession or our healthcare world anyway. So when we look at this a little bit like a totem pole, kind of looks like a spine, doesn't it? The bottom level there, the sacrum, is your chiropractic board of examiners. And there are a set of rules and regulations that apply to you. I would add maybe a little disc right above that is actually your malpractice payer, because there are a number of things that your malpractice carrier expects of you from the land of compliance and the land of keeping yourself safe. The next three are state level sets of rules. There are rules that relate specifically to your fees. There are rules that relate specifically to any kickback and Stark. There are all of these things that apply with your state Department of Insurance, et cetera. Then we get into the federal rules, which are the anti-kickback laws, the Stark laws, and then sort of that occiput of the whole thing, looking over everything, is really the Federal Office of Inspector General. So when there are revisions, there are two kinds of revisions that happen every year, big revisions. Obviously, CPT and ICD-10. ICD-10 is run by CMS. And actually, they make changes 4 times a year. But October 1st of every year is when all of the changes go into effect that are good until September 30th of the following year. So they run on a government schedule. As you know, the government kind of runs on that October 1st to September 30th time schedule. CPT, on the other hand, were notified in October of any changes because all of that is run by the AMA and in concert with CMS, but also all of the specialty groups for every single different type of profession. And CPT is managed that way. So we hear about the changes now, and then they go into effect on January 1st. So your ICD-10 changes, which again, there were not much of anything. I'm going to show you what even remotely applies, already is in effect. ChiroTouch is amazing about getting all those changes into your systems and updates ahead of time. And then any CPT changes are going to happen starting in January. So you know that as Medicare goes, so goes the nation, and that means that the payers will follow. So when these regulations and things are published by CMS, the payers all review those, because to some degree, and especially in Medicare Advantage plans, which are kind of governed under the CMS heading, even though they're private companies, this is one of those things that the payers will look and they'll see what applies to them and how they need to perhaps tweak their own rules. This is the reason, for example, that the medical necessity definition for chiropractic is almost exactly the same in payers as it is in Medicare for all payers. The edit makers are then what we call the NCCI guidelines. Now, these are the National Correct Coding Initiative things. So if any of you have ever tried to bill a 97140 manual therapy with an adjustment and it gets bounced, or a massage and it gets bounced, these are because of the NCCI edits. So payers, for example, follow these same edits and they grab them and they apply them. Sometimes you can have a modifier, sometimes you can't. But this is where all of these rules kind of come from so that you understand. I literally had somebody yesterday in a consultation ask me what CMS meant. So we talk to people from every angle. You could be very first time ever on a webinar. So I want to be sure that as I talk about these acronyms, you understand kind of why I'm sharing this information. CMS is that government agency that oversees everything for Medicare and Medicaid. You have certainly AMA, which is the American Medical Association, that kind of owns the rights to the CPT codes, and we deal with that. NCCI is overseen by CMS. These are all subcategories, if you will. Now, the contract makers are all of these payers, and you may actually have some sort of an agreement with these people. Maybe you don't. Certainly, if you do not, we always recommend that you are not billing for your patients. Why put yourself in between your patient and their insurance company when you've made a conscious decision not to be a part of it? So that's a whole other webinar. But then you get the compliance king and queen. And of course, this starts with HHS, which is kind of the government agency. As you all know, this is where RFK is now the secretary. And then underneath are a number of agencies. And one of those is the Department of the Office of Inspector General in this department that oversees kind of the legal and all of those other things that are a part of it. Now, it used to be that this was all that we had to worry about. And now there are other things that have joined into this compliance party. So underneath HHS, we also have everything related to HIPAA. And, we get people all the time that will ask us, oh, I don't think we need to worry about any of this compliance stuff, right? I'm a cash practice. Okay, well, guess what? Every one of these things applies to you. And what I often tell our clients that are cash based, obviously you can't opt out of Medicare, so you have to deal with that. And HIPAA is the one thing that can bite you in the fanny and close down your practice. I've seen it. I've seen breaches. I have seen computers explode without a backup. This is where your greatest risk is overall. And if you're cash based, it's probably the biggest thing that you have to deal with. But what you can see here is that the Cures Act, which is information blocking, and it's more stringent than HIPAA in many ways. High Tech, which gave teeth to the security rule, and those are updating again come January. Your state data privacy laws, and then what's called SAMHSA, which is part of HIPAA that creates the rules that expand into health records. So it's a lot. It's a lot. This is one of the reasons a company like mine is in business, just because we have to keep track of all that. In fact, I leave tomorrow for my annual conference where I go to get all the updates, or at least the biggest updates, and get my own CE credits for all of my certifications. So we have to stay on top of this. Now, you might have seen that some people in the profession, some other consultants may have come out in this SAMHSA and told you have to update all of your HIPAA program and all of that. It is really important to know that this is specifically around substance abuse and mental health. It did not make a major change, but it is important that you're just simply aware of it. And I hope that this isn't what you're thinking right now, because I didn't mean to do this to you at all. But what I find, and I can say this now with 42 years in the profession, in this profession that I love, is that very often we stick our head in the sand and we think things don't apply. And in the way that it may apply to you, in the most velvet glove way that I can possibly share, I need you to be aware of these things, because you are a business owner in a highly regulated industry. And while the clinical stuff is primary and paramount, your business deserves the same attention as do your patients, because this is not only your livelihood, doctors, but it also is living within the laws that you have agreed to by being a business owner in healthcare. So what I want to do is just talk about 3 big things in this brief training that I think are the most important things to be thinking about in October of a calendar year. So first of all, know the rules. You have to exercise your Google muscles and know what these things are. And these are all the most important sites for you to be aware of as a business owner in healthcare. You can find your own ICD-10 coding updates, and this is what it looks like. So just know that along about July every year, we are going to get what those changes are. We're going to get also the crosswalk to show what the changes are. And we're going to get the new documentation and coding guidelines that come out. Now, oftentimes there aren't a lot of changes to those, but we need to be aware of them. We make it our business to know them inside and out so that we can advise properly. But just be aware that this is what the timing looks like. Reading the descriptions of the changes, and I'm going to show you an example on the next slide of what to kind of watch for. But review the official guidelines for that reporting year and see what changes. This is one of the things that is in every single one of those, and I think a lot of times we forget. But I'll find, as we're doing a proactive chart review for a doctor that's asked for one, that most of their diagnoses are very simple, like cervicalgia, lumbalgia. And really what these guidelines say is you're obligated to code to the highest degree of specificity, not only in CPT, but certainly in your diagnoses also. And so what that means is that if somebody's got a disc degeneration, or you just didn't want to have to go that deep, cervicalgia is not enough. And that's I'm going to use a nice air quotes way to say lazy way to diagnose. So you're expected to follow those guidelines. So if you've never seen them, you ought to find them. You're obviously with the greatest company in chiropractic with software being ChiroTouch. They make an effort and they work with us to get those updates, as soon as we know what they are, to make sure they've updated the systems to flow those down to you by October 1st every year. You have to make sure that whoever's entering charges, doctors, staff, who's scrubbing claims, everybody's aware of these changes. And again, always to the highest degree of specificity. So this is one example of what I wanted to show you about any changes. As you will see, they probably have very little to do with what most of us are dealing with, right? But Chapter 13 is the chapter that are our M codes, the most common codes that we use in chiropractic. So what we see here is that there was a code added, and that addition had to do with a rheumatoid factor and a protein antibody with rheumatoid arthritis. It belongs in M's because it's musculoskeletal, has nothing to do with us. Then you notice that there are some revisions. So you take something like this, that's a varus deformity that was not elsewhere classified, and they changed it to a varus deformity that's an unspecified hip. So all they did there is get just a little bit more precise, and who knows, probably orthopedists or who requested that change, but it may or may not affect you. A loose body and unspecified toe joints, the only revision is that they put parentheses around the S. So we absolutely 100% scan this to make sure if there's anything at all that is pertinent in our profession and surrounding, PTs and such that will let you know. You can also see that they do a code first change, meaning that's your 1 and 2 that you have to look up, and they want to make sure that if there's a disease of the blood in this instance, which are all the D codes, that is done before something else. And then the last one, we do use myositis, a particular amount in our profession, but you can see that myositis ossificans progressiva is something that they just did an unspecified upper arm instead of an arm. This is the level of granularity that we see. And this is what, just as one example, I want you to feel confident that we've been through this. There are no big changes that you have to worry about for this next year until September 30th. The same goes for CPT. We partner with the ACA. We partner with many members of the ACA's coding committee. And if there are going to be any CPT coding changes, that's going to happen starting in 2026. That would be January. But we have looked through everything. There is nothing specific to the general codes that we use in chiropractic. Those are your E&M codes. Those are your CMT codes. Those are your PT codes. And, if you are a specialty practice and you do things very much outside of just kind of those parameters, then it would be important for you to do a little bit of research and make sure that you know what's going on there. We definitely recommend this every year anyway for a year-end activity. Those of you that have worked with us on implementing compliance have a compliance calendar. That's our most important thing. And we take these annual duties and spread them out across a whole year. So one of the things that you're going to find, and we're, I think, going to try to look at it here in a second, is that we look for what your payers' provider manuals and medical review policies, when their next review is, get that into our compliance manual a little bit ahead, and then make sure that we're going to see if there are any updates that we need to be aware of. As we work with a practice on denials, or they're struggling with something, we get a lot of questions about, should I use a billing company or do it in-house? Bottom line is, whether you use a billing company or not, 50% of the work is done in the walls of your practice. So even if you use a billing company. So if we don't get these things right and do the coding right according to what the payers say, that's not a billing company's job to tell you what those things are. We're still going to have problems. So what we find is that most practices are not doing these basic things: knowing what the medical review policy is, updating it, checking for modifiers, etc. So we're going to do a test, and we're going to jump into, let's look at this Aetna one. So this is simply Aetna Chiropractic Services, right? But the thing I want to call your attention to is the last time this was reviewed was April of 25. The next review is January of 26. So I would want to see that in your compliance calendar that you're looking at now at the end of the year, that you are actually putting something to go back in and check to see if there are any changes. You can see here, this is the CPT ICD-10 codes. So when there is a change from CPT, these payers have to update their medical review policies. So if you go here and there are not changes to those medical review policies, you actually, are able to see something on, through the payer without having to go look it up yourself. And you can see these are all the things that they have in here, all your physical medicine, rehabilitation, and PT kind of falls under a lot of this. And then we get into the codes, and these are the codes that they feel like you can use. Now, again, you can see here ICD-10 codes covered if the selection criteria are met 0 to 3 years of age. This is their children medical review information and what you're allowed to bill based on, a child. It's going to go on and on and on and get into a whole bunch of other stuff here. I just want you to have the general gist of, generally, these medical review policies will give you all of the information that you need. And you can see codes not covered for indications listed. And these are things that wouldn't be covered. And doctors, God love you, I'm sure you got enough to do. And maybe you just have never gone to this level. Now, the entirety of the rest of this is literally going to be hey, this is what chiropractic is. This is why we made these decisions. So it's just important that you're aware of what these are. And I'll tell you that I actually kind of hope that you don't try to I don't want you necessarily to try to download these and keep these things, because really, um, it doesn't do you any good to download them, because they're changing all the time. I would rather you keep track of the links so that you can go back. Now, another thing that's really important is to search the exclusions database. Now, really, you're supposed to do this quarterly. And this is part of the fraud, waste, and abuse training that's required annually for your practices. But searching this exclusions database is actually very, very simple. You can see it's on the Office of Inspector General website. You search for an individual. You should never, 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 never hire somebody without checking this. And then, as part of your compliance activities, basically you're rechecking it quarterly. Now, if you're a husband and wife and that's all that's in the practice, you might have some leeway there. But I have a list of clients who have actually got in trouble for having hired someone who was on an exclusions list, and the fines are ridiculous. You don't need this for the 15 seconds it takes you to go and do this. What I want to show you, though, is this is where that website is, exclusions.oig.hhs.gov. If you just go to oig.hhs.gov homepage, you can have a link for exclusions. And then this is really great. The physician education is here for guidance for individual and small practices is there. These are all the things that you can do on your own. And everybody needs to be aware of what's happening with Medicare Part C, because it is by far and away the area of the biggest mistakes that are made by folks in our profession. What you think you can do, what you thought you could do, etc. It is an area of training that you need, and every person on your team needs. This is the time of year when open enrollment happens, both for physicians and for patients. So your patients at this time up until the beginning of December can change between original Medicare B and Medicare C Advantage, or vice versa the other way. Additionally, providers, in Medicare Part B, you can change from par to non-par or non-par to par. This is the only time you can do it for an effective date of January. And then if you miss it, you can't do it again until the last quarter of next year. So be aware of any changes that you may want to make and be on top of that. And of course, take a look at your ABNs. The ABN situation, I just scratch my head at how often people are still confused by the fact that an ABN is only for your 3 spinal CMT codes when the service is maintenance. You got to clean it up eventually. Yes, you should have some kind of voluntary notice that the patient is aware they're going to owe for all the other stuff, but don't use that official form. And you cannot use Medicare's black and white ABN form in Medicare Part C. Your Part C payer may have their own, and if they don't, then you can make one more like a voluntary, but you have to do something or you do not have the right to charge them. So moving on to the next section is your financial cleanup. So at the end of the year, I always like to talk about this. Financial cleanup happens at the end of the year. I think it's always a great time to do it. Not that you shouldn't be cleaning it all the time, but it is a great time of the year to just sort of start fresh with a new year. And I'm going to talk about these 3 things that I think are wonderful, wonderful tools that you can work with. First thing is, doctors, you should know what your accounts receivable is. You should know how to look at it. You should know how to look at unpaid claims. Office managers and billers, of course, should be looking at this all the time. But you can sort it and organize it. And what I find, as we're doing an accounts receivable review for an office, that when we're going over it with the doctor, we'll do like a sort of, say, this patient balance. I can honestly tell you that some doctors are like, what the hell is this? I had no idea. And I don't want you to be in the dark. I want you to delegate your department, but I don't want you to abdicate it. I want you to be aware, because this is your cash flow. This is all of it. Your regular meetings that we recommend, a stand-up meeting weekly, a more in-depth meeting monthly. These are the things that I think are going to be the most important for you. What is being written off? Are we writing off things that we're just not taking our time to go in and look at? And your payer receivables can be divided by payer class. Or case class. This is a great way to get in. And, if you have to do some immediate work on something, sorting it this way is really, really great. This is a great tool that those of you that are members of our program can access right in our library. But this is something that when we're doing a review with someone, we want them to go in, pull this data, take a look at it this way, and then, figure out what follow-up is going to bear the most fruit. When someone comes to us and they're in a cash flow crisis, this is the first thing that we do. We go in and look, we find the low-hanging fruit and figure out how to get that in the door as quick as we can. And then you're going to target this 60 to 90 day area so that we can jump on our horse and ride and get this stuff going. End of the year insurance cleanup can also be done right here. And then this patient can be even including our amnesties and other things that we're able to be doing. Speaking of an amnesty policy, I think it's a good idea. It's an opportunity for you, for all of the patient balances you've been fighting with, to give the patients an opportunity to clean it up. It can be part of your financial policy. Remember, we charge correctly, we bill correctly, we can collect according to our policies. When collecting in full is failing and you've got a mess, even a small mess, this is a great way to clean it up. So amnesty by definition is just basically a pardon. It's an act of forgiveness. So this is something that we kind of work with some folks on doing. And I absolutely think it's a wonderful tool that you can say, here's your balance. In the spirit of the holiday season, Doc is offering a one-time amnesty, pay your balance in full by X date and take 50% off of what you owe, or whatever number you want to have. Doesn't matter. But this is a courtesy we're only offering now. And then obviously your collection procedures would continue. Maybe you turn them over to collections after that or whatever. Set a short time limit, set a percentage. And, there also is the option that you can actually do a courtesy write-off of all of it. If there's a chicken feed balance of, $10 or $15 that you've been fighting with, once you have done your attempts to collect at this point in time, it can be done according to your office policy. This is not a blanket. This is not what you do on day 2 of when the balance exists. This is something you do for an AR cleanup down the road. And there are very clean and easy ways that you can do this. And if you're going to get rid of a balance, then get rid of it, and send a note about it. Don't just write it off. And I think I have a slide that'll tell you what to say about it. Always offer payment plans, especially for larger balances. Wouldn't you rather get $50 a month over a period of time than nothing? Maybe they can't get their arms around an $800 balance, but if you did a $50 a month scenario, it'd be paid off in a year. Get their credit card, keep it on file in a legal way, charge their card automatically. That's the way to manage accounts receivable. On these automated payment plans, this is great. Thank you for your payment today. What I'd love to do is set this up to charge this $50 each month until your balance is zero. The last month, if your balance isn't the full $50, of course, it will only be this. Let's figure out what's affordable so that you don't have to keep ducking this balance, right? And here's what I was talking about with year-end balance forgiveness. And, use it sparingly, have a rationale for it, and always notify the patient. And you pick a number, $25, $50, somebody that has been in a lot of trouble, a lot of challenge. And you can send a note that says, Mrs. Jones, you've had this $25 balance for 9 months. You haven't been able to pay at this point. In the spirit of the season, I want to let you know that I'm erasing this balance due. You have no balance at this office. I never want you to feel like you can't come back because of any embarrassment or anything else. I know you've been struggling. I'm happy to clean this balance off, and you're free to come in at your leisure. Now, of course, this might be somebody that you make sure is paying at the time of service, so they don't do this again. But this is a really nice tool that you can do for many ways. So again, help your people understand they've come to the right place with that financial policy. understand that that financial policy is according to your practices, how you want to take payments, how you want to offer payment plans, and make sure that they understand they have a financial agreement with your practice. It's going to set boundaries, it's going to affirm agreements. An informed patient is much more compliant patient for sure. And generally, you also have your compliance policies that are your internal policies, such as how you deal with your contracted and actual fees. These are all things with your compliance program. And then if you wish to have a hardship policy, go for it. No problem. Make sure that you are documenting it, that you have a sliding scale. It's not hard to do. We have a great system in our library if you're one of those members. And don't forget that the No Surprises Act requires you to offer a good faith estimate to anyone not using insurance. And please, please do not miss this. The rules were supposed to change January 1st. They are not changing, but now we're getting into a time where the rest of the No Surprises Act is coming into play, which is called Advance EOBs. And I don't want to rock your world with that right now, but just know that it's coming down the way. As you're going, keep a log. Figure out if you're a collector and a biller. My personal goal is to make sure all these accounts are in order. I'd love to help you get this balance resolved when you're making a phone call to the patient. So I think those are very, very important things. Last but not least, we're going to talk quickly about the end of the year checklist. These are all the things that belong in your annual compliance duties. And like I said earlier, I like spreading these out over a number of months, because why do them all in December? That'll kill you. But this is something that you can do a little bit over a year. This is how we make compliance digestible and easy and not so time consuming. Shouldn't take you more than a couple of hours a month, quite frankly. And then you have these rules around HIPAA. Again, HIPAA can be the biggest thing to bite you in the fanny. Make sure your yearly risk assessment is done. Make sure any corrective actions are managed. Go back and look and make sure all of the permissions are correct with everybody who has any kind of a login. Has anybody left? Go back and make sure that you've got those all buttoned up. This is your time of year to just really start January fresh. These are all of the things that you need to do financially. You know that there are going to be changes to your Medicare fee schedule starting January. Make sure your ABNs have the correct fee schedule if you're charging that fee or the limiting fee. Update all of your payer reviews and updates and fee schedules. Take a look at your hardship policy. Look at all of your forms and see what needs a refresh. Make sure you know, again, no big changes on these other things. So, to improve is to change, to be perfect is to change often. And no one is going to be perfect. There's always going to be changes. But I urge you to look at these things and think about what could apply to your practice. You've got a good 2.5 months before the end of the year. Pick 1 or 2 things that you can apply and make a difference with. And I think it would be awesome. I'm going to just show you a couple of quick things, and then we're going to turn the time back over to Sawyer and Justin. Not sure if you know, but we have podcasts now in YouTube and Apple Podcasts and Spotify. We've taken our help desk videos and turned the audio into these things that you can listen to in the car. You can do whatever and get your information now a different way. And this is a gift to the profession. We're doing this publicly at no cost. So definitely go check it out wherever you listen to your podcasts, and certainly like and subscribe. And as we always do with our ChiroTouch webinars, should you wish to start the year great and be a member of our membership, which includes all of that training in the library, a live and email help desk, and all the rest, we're offering a full month of library at no cost when you sign up. So we'd love to have you use this coupon code CT-FREE-M. And of course, if you haven't done this, go join our Facebook group. You can search Chiropractic Reimbursement and Compliance Experts. You can use this QR code. We have a very big and robust group. It's monitored by certified compliance specialists. So you're not going to just get any Tom, Dick, or Harry trying to give you an answer, as I see with, good God, every other Facebook group out there. And I kind of am frustrated with even being in those groups because I feel like I have to correct everyone's answers. But if you're in here, you're sure you're going to get the right answer the first time. And as always, if there's something here that you had a question about, this is the best way to reach us, info@kmcuniversity.com, and we'd be sure happy to talk about any of those things that we talked about today.
Awesome. All right, Kathy, I'm going to go ahead and just tee you up with a few different questions that we received in the chat. All righty, so first one here, I have a patient that has Aetna Medicare Advantage. I'm not in network with Aetna. Do I have to bill, and do I bill properly given I'm not in network with Aetna?
Yeah, I'm going to tell you that if you're properly enrolled in Medicare Part B and you are not any part of Part C, you still have to verify every Part C person through your Part B portal to make sure they're not a private fee-for-service patient. If you bill, you have to accept their fee. If you want to be completely outside the boundaries of that, then no. But the rule is that for active treatment, AT, you do not charge more than the allowed fee in Part B. So it would either be your limiting fee if you're non-par or the allowed fee if you're participating. Up to now, we have no guidance. We've searched, we've researched, we've written to CMS, and we can find nothing that says that if you're outside of that, other than private fee for service, that you have to bill it. We say provide a super bill to the patient, make sure that you know those private fee for service and that you charge no more than that Part B fee during active treatment.
Awesome. Not sure if I can put you on the spot with this one, but another question we had earlier is reporting code G8939 still needed when billing Medicare?
Those G codes kind of went by the wayside unless you're participating in MIPS. So if you're not doing that, those codes have not been necessary for a little while.
Gotcha. Next one I have for you here. Can you please address requirements and standards of care / frequencies for exams in chiropractic?
Yeah, I mean, I think it's important to know that the E&M component of your chiropractic manipulation code has E&M things in it. It just automatically does. This is the reason you have so many payers now that are saying we're not going to pay for that on the same day as a CMT, even with the 25 modifier. Some are saying you can only get paid for one once a year, blah, blah, blah. There is no specific requirement unless it's a payer requirement in a medical review policy that you have to do a formal E&M. But I would ask you, standard of care wise, how are you going to get all the data that you need, history, all of the history on the patient, et cetera, outside of that for especially a new patient? For reevaluations, you have a choice. But I'm going to tell you, if you're not charging for it, you're still doing quite a bit of work within the confines of that CMT because it has to be more than a standard routine visit.
Gotcha. All right. Next one I have here. Is it true that you only need to do a GFE for cash?
Yes. Anytime that a patient is not using their insurance at all, the GFE has to be offered. If the patient declines it, you don't even have to do it then.
Gotcha.
Only when not using their insurance.
Perfect. Another question here. Where can we find the Medicare fee schedule?
It's on the website of your Part B Medicare administrative contractor. So I live in Colorado, that's Novitas. If you're in Maine, it's NGS. Right on their website, which should be, by the way, a bookmark for you because you're going to be in it a lot. On that, first of all, make sure you're enrolled in their portal, whatever their portal's called. But on the actual homepage of that, you always find a shortcut to fee schedules. You might see the CMT codes listed twice, and one of them has a pound sign. Sorry, you guys call it a hashtag. I'm a geezer. They're pound signs to me. The hashtag in front of it. The hashtag is for if you are in a facility. So use the fee that has no hashtag next to it.
Perfect. This one was pretty popular. Can you use the ABN with Medicare Advantage patients who switch to maintenance?
So first of all, you always need advance notice. If that's the only purpose for an ABN, actually, is generally when that happens. But in Medicare Advantage, they either have their own form or you have to create a form in that way. And that is just to kind of be upfront about the patient wants it and they're willing to pay for it. Don't use the Part B ABN as we shared.
Gotcha. Thank you so much. I think we have time for just one or two more comments. Kathy, as you mentioned using ABNs for maintenance adjustments, does this mean we would not use ABNs for exams and therapy?
Of course. That's exactly the rules. It's been the rules forever. Unfortunately, people have been misinformed. An ABN form is only for an otherwise covered service, 3 CMTs, that may not be covered today. And that means that's what an ABN is for. Should you do a voluntary ABN? Maybe you jumped in late, but we actually had a slide on that where we talked about a voluntary ABN. Our recommendation is that you just do something on your letterhead. If you're a library member, we do have that template right in our library, and you can kind of just notify. Because if you use the black and white ABN form, they can't sign it and they can't select an option. So just don't do it. By the way, you don't have to, by law, tell them that something that is never covered or never a benefit, you don't need to advance notice that at all. But it's a good idea and it's best practice. So you should do something.
Awesome. And then just a little follow-up to that one. Do we need the NEMB as well as an ABN for patients?
The NEMB went out of circulation many years ago. So the answer is no.
Okay. And then last one we have time for says, can you ask Kathy about modifiers for massage codes?
Depends on what the payer says. Most often, it's either the 59 or the X corresponding X modifier. Plus, many of them want GP. If it's Medicare, GY is added to all of that. But it's going to depend on each individual payer. The joke is that nobody, including AI, can actually tell you what modifiers you need. Only the payers, like we know best practice, but the payer's medical review policy is where you get those answers.
Awesome. All right, Kathy, thank you so much for this today. I did want to save us just a little bit of time to talk about something new and exciting that is coming to ChiroTouch. Justin, the floor is yours.
Thank you, Sawyer. For those who don't know me, I'm Justin, Senior Product Manager here for ChiroTouch. And we're really excited to introduce this feature. We've been in partnership with Kathy on this. She's been giving us some solid feedback. As she mentioned, there's a lot that AI can't do, but we're going to try to empower our systems to deliver as much AI assistance as we can. And so one thing we've been working on is kind of your compliance. We're also looking to help you from a software standpoint. So kind of hand in hand, Kathy and her team can help you with compliance, but then also from a software perspective, we're looking to look out for you as well. So for those of you on the cloud, this may look a little bit different from the screen you're used to looking at for charting, and that's because it is. We're looking to surface some new information for you all. And if I can direct your attention all the way to the right over here where we see risk level, our systems in the near future will be starting to analyze risk on your chart notes to understand, is this note compliant? Does your note match what's going on in your diagnosis and also in your charges? And so we'll be starting an automated process that will start to analyze these and pull these to the top for you and display them in a nice little dashboard so you understand what is accessible. So if I go over to the application, so this is a mock-up right now, but if I go over to the application today, this is what we have live that we're working with. A few customers are working with this and giving us feedback. So I have my daily note here, just a basic note, but we realized that I have one diagnosis here and a 98941. If I look at my compliance, the AI is going to score me at a 50. And this is because we mentioned regions in the note that are not mentioned in the diagnosis. So we see thoracic is here, but we don't have the diagnosis codes because the AI read the note and said, hey, you're missing this M99. And then also we're billing for a 4-1 when we are only treating a 1 to 2 region. So if I go ahead and quickly add in a M99 for the thoracic region, save that diagnosis, as well as switch my coding to be proper. and I add that charge in, swap it out. And if I give it a second to run our compliance scan again, this is again in real time running the AI. We'll check the node again, and once this returns, it'll be 100%. So those of you who are on the cloud, you do have an opportunity to opt into this. We will email out cloud users to see whoever attended this webinar, if they want to join our early access. We see here that we have a 100%, and we have a few info suggestions, as well as notating that we're only checking 9894 codes and M99. So we're starting with spinal manipulation and N99 diagnosis, and we're looking to grow this out into more codes. And like I said, we've been working diligently with Kathy to even pick up things in the note that we need to pick out. And I see a couple questions in the chat, and one of them I do want to call out. This is cloud-based only, so don't want to cause any confusion. This is for our cloud customers for this time being. As technology is a little bit tougher to implement on Classic, or on the server. We're trying to do our best, but right now this is for the cloud. That's our compliance scan, and we're really excited to get this out over the next couple months.
Awesome. Justin, we had two just quick private questions. One, will compliance scan be available for core and CT advanced?
Correct. It will be available for core and CT advanced. So not just limited to our advanced customers, but also those who use our core function.
Awesome. And then last question here about compliance scan. What codes are your team focused on now, and how do you see compliance scan continuing to evolve?
Great question. So we're currently finalizing and iterating on 98940 through 42. As those are spinal manipulation, and continuing to partner with KMC about how we can further tweak those. But then we're getting into 98943 and as well as 97 codes, so some time-based therapies, and working through some of the nuances there for the AI to be able to pick them up and train it accordingly. So our target is to look into the most used codes and expand from there. But ultimately, the sky is the limit with AI, and that's what we're trying to prove here.
Yay, super exciting. All righty. We have a few different QR codes that are up today. So I'd love to invite you all to scan the QR code on the screen to connect with Kathy and her team at KMC University. And if you're not already with ChiroTouch, just a secondary QR code there to learn more and connect with us and our team. Just really wanted to take a moment and thank you all truly for making the time to be here with us today. It really means a lot to us, and we understand that you are all busy, so thank you for that. Thank you all again, and I hope you all have an amazing rest of your day.
Bye.